So let's take a look at the patient's upper and lower arch. The upper and the lower arch is good. The arch form, okay, is good. Okay. So after the patient has some posterior open bite and the upper arch is narrow, we stop for another new scan and put the patient in AA1 or the second set of aligners. And on the second set of aligners, we continue with the MA because I want to advance the mandible further because the patient is severe to start with. So with just 35 or 36 aligners on the first set of aligners, it's not good enough for him. So on the second set of aligners, we did another 34 aligners for him. So that's about 8 to 9 months extra. So as you can see here, okay, during the initial, okay, this is the final position on the final stage of the first clean check. And then after the patient finishes his upper and lower aligners, can you see? The canine eminence is larger here. And the lower canine eminence is more lingually, it's more lingual version. This one is more buccal version. So the overbite and overjet over the upper left and lower left is not good. The arch development is not too ideal. They are not coordinated after advancement because with this type of patient with midline deviation, we usually tend to have a symmetrical jaw. That means one side is more than the other side. And if one side is more than the other side, sometimes we tend or we neglect to look at the overjet. We neglect to look at the canine eminence on the final stages. And sometimes it doesn't induce the tooth movement or the tooth leveling and alignment of the tooth.
Sure.
Because your aligner have wings and it's also doing leveling and alignment. So if you're doing a lot of mandibular advancement, do not put a lot of bireps if you're doing MA because it will weaken the wrap of the upper incisors. So if you want bireps, MA first and then continue with bireps, but not together. It's gonna weaken the upper incisors of plastic wrap. So on the second set of additional aligner or the third scan, we coordinate the upper and lower arch and allow more lower lingual buccal of the side. I think the upper arch is wide now. However, on the lower arch, we want more buccal portion over the lower lingual side. And this is the patient after 2 years. I think it's good. Okay. This is him. Okay. He's more able to smile better. Because with this type of patient, the muscles, especially the orbicularis muscle, they are very hypoactive. It doesn't contract. It will take a lot of exercise. So when they smile, all this the angles of the lips come down, like grandmother. So they need to train, their orbicularis muscles as well. And his skin is much better, less pimples. And this is him after the treatment with mandibular advancement. Even though not the best chin button I want, but because genetically he's a very severe mandibular retrographic patient. So we just want his dentition to come into class 1 and to free his mandible in a more posterior position, backward position. Okay. And after the treatment, he went to the Philippines to further his education in medicine. So I'm really happy for him and look at how his mandible is able to auto-correct and self-correct after we're able to free the mandible. And he has the chance to grow more on the side that is short, with a shorter ramus height. And this is his panoramic before and after the treatment. The 8 are still intact. Okay, so pay close attention here, because if the patient starts to wear his retainers, the force from the wisdom teeth might push the 7 to 7, and he tends to get a little bit or a slight relapse of the lower incisors. So usually with this type of teeth, I will always warn them and tell them that they need to keep the retainers on until they decide to extract their wisdom teeth. If they don't extract their wisdom teeth, they have to wear their retainers as long as possible. And usually with patients going abroad and patients that finishes with MA, I like to use Vivera or Vibrant. And about 90% of my patients uses Vivera, 3 sets. I don't usually use the 1 set because 1 set is not good. Because if they have something emergent or they broke their retainer, they don't have any backups. And it's also good for our practice because they don't have to come in often. And it's good for us. And usually with Vivera, after we do it with scanner, it's very fit. It's very precise. So in the earlier days, when I have retainers, the patient have to make an appointment to come in to pick up the retainer because I need to fix it. Because the suck down manufactured or created by our staff is usually not very fit. So I have the patient come in, I have to check everything is good, it's not good, I'll do the hot bath water, or we learn with the fan to hit the aligner, to hit the plastic, the retainer, so that we're able to modify or to adjust the size or tightness of the aligner to fit better on the dentition. And he just flew to the Philippines with his Vivera, and I only see him every summer. He comes back. And look at his chin, okay, and his airway. Look at his airway. Can you see this one? And this one? How much difference? This is scary. I've never, paid good attention on the airway before I do MA. No, never. Safe for me is not airway. Safe for me is SNA, SMB, AMB, and width, okay? But never the airway. Now it's the airway and it's also the CVS. Okay, you can check his vertebrae to see if it's at his peak of puberty. Look at his airway, that is very scary. And by doing this, you're helping him because you're expanding his airway, allowing him more volume or more oxygen to be bringing him into his body. And it will help with his circulation. You won't have, we call it cold body. In Chinese medicine, if you have a cold body, you have a poor circulation. And everything won't be good. Okay? You get tired easily, your brain is lack of oxygen, you tend to be drowsy, it's hard for you to focus, you get sick because your immunity will decrease and your concentration will decrease, you don't sleep well, and even though you sleep 8 hours every night, you still feel very tired in the morning. So we are helping him not only with his dentition, with his facial profile, but also his overall health. And the amount of overjet that's corrected, 8 millimeter in total, with MA, no elastics, okay? No distalization, no surgery, no activator, no Byrex. And this is his cephalometric. If you ask me, do I do the tracing myself? No, AI does it, okay? This is AI, and it will give you the report, okay? And this is called WebCeph, okay? Jot it down, WebCeph. You can just upload your cephalometric, and then you just need to jot the endpoint and calibrate the ruler, okay? But you need to know the deviation. For my cephalometric, it's 1.2. So for 10, it's 12 millimeter. 10 on the ruler is 12 millimeter. That's called calibration. So you need to check, the deviation of your X-ray and the real, the person. Okay. So after we superimpose, we can see there's a downward mandibular growth. Okay, and retroclination of the upper and lower incisor. This is very important because the side effect of functional plan is labial tipping of lower incisor. However, with mandibular advancement, we're able to keep the inclination, we're able to keep the torque and prevent more labial tipping of the lower incisors. And if there's more labial tipping, the side effect is the patient. It's hard for the patient to do more mandibular advancement because the incisal edge of the lower incisors touches the upper singular. The lingual singular on the upper incisor. So it's hard for the patient to jump further. You need to change the inclination so that the mandible is more able to come out in a forward position. So that's the first case with excessive overjet. So now, when you go back to your practice, your clinic, and you are looking for someone that is overjet of 10 millimeter, and in his teen years, or in her teen years, and maybe you want to try MA instead of traction, and instead of elastics, and you see the miracle for yourself, and for the patient as well. Now we're going into the next case. The next case is a deep bite. A very brachycephalic with hyperactive masseter muscle, in which when you see this type of face, okay, maybe one jump till the end, so he doesn't crush the wings. He is in his 16 to 17 years of age, a little bit older than the last patient. Okay, you see, after I have a lot of teenagers, I tend to have kids that are more males than females. Usually I have more females than males. Now all the males are coming in, and usually with the males, sometimes it's really severe for them because the growth is slower than females. So they tend to, hide. Men will tend to hide in a more distal backward position. So he has some posterior crowding here on upper 1.6, okay, lower 4.5 and 4.6, and deep overbite of about 80% or about 6 millimeter with mandible retrosynaptism. Okay, the chin is facing downward and backward. And on class 2 here, about class 1 here, midline deviation. If you have one side class 1, one side class 2, the midline is always, usually, 99% off. I cannot say always, because if you have one incisor missing, maybe they will be on. But if the teeth are all the same on the upper arch and lower arch, if one side is class 2, one side is class 1, it's usually the midline is off. Then you will need a symmetrical jump to open up the bite and correct the midline. And this is very efficient and very comfy and very, I think it's very neat to use because you don't have to pull transverse elastics. You're able to customize the different length of the precision wings to help with the transverse correction together with the sagittal. And not only the arch expansion, but also the midline deviation. It's also applicable together with the MA feature, the alignment and leveling of the dentition, and also the midline. We did 2 clean checks for the patient, and the total treatment time is 2 years, 5 months. So this means there's something crooked on the posterior. Maybe we'll enter a stage called pre-MA. So the patient is a class 2, division 1, okay, almost division 2, but his incisors are more upright. 1, 6, 4, 5, 4, 6 are a little bit lateral version. Deep overbite with narrow arches and a small chin. His overjet is about 6.2 millimeter. Okay? So in the final position, you finish a patient with a final position of overjet 6.2. It's not very stable because the lower incisor is biting on the cingulum, on the upper incisor, and this cingulum here is very near the center of rotation. That's why this type of dentition on the upper arch will be open, it will be gapped. So we need to finish with the lower incisor biting on the lower 1/3 of the cingulum on the incisal edge. So he's about 6.2 over jet, 5.1 over bite. We want about 3.4 millimeter of correction on the upper arch and 5.6 on the lower arch, because I want overcorrection on the big bite. He is the big bite to start with. So the treatment plan is to do expansion on the upper right and lower right, okay? And correct the arch form into an ovoid arch form. And do more anterior intrusion on the upper arch and on the lower arch. If the patient is more gummy, you do more upper intrusion. If the patient is less gummy and the curvus P is large, you do more intrusion on the lower arch. For this patient, I do more on the lower arch. As you can see here, the curvus P tend to be large on the lower arch. And we want to correct the midline and MA with a symmetrical jump. MA with a symmetrical jump because there's a difference in the length. We need to train and to teach our patient to advance the mandible and position the mandible in a more forward position before he engages the wings inside his mouth. So you can ask the patient to move the mandible in a more forward position. Practice, okay, like 20 times before he wears his aligners with the MA. It will help him better sit the MA in position. So let's take a look at his clean check. So on the first clean check, the same, 6, right? 6 point something. 2 millimeter in front of upper incisor. That is the final position. And after I start to do this, I have more, better result at the end of MA treatment. Otherwise, in the early days of MA, I usually find it not enough. You know, the mandible position can be more forward. It's always not enough. So I changed after some experiences with the MA appliance. Take a look after 1 year, okay? He's a bit older. He's about 16.5 months, I guess. It takes him about 1 year, okay? And his muscles are very heavy, strong masseter muscles. This side is good. This side is not too good, right? Because the MA gets crushed on his treatment and during his treatment. Even though the divide is a little bit corrected, about 1 to 2 millimeter here, okay, but not much. Okay, so we continue. I asked him, okay, to do more mandibular advancement exercise. But during this stage, we can see the palatal cusp hanging down here. So the bite here is not too good. The buccal overjet is big. So overhanging palatal cuff is very common in distalization, in expansion. And you will see when you move buccally or you move distally, the cuff will hang down and it will induce interference or collision with the buccal cuff on the lower arch. And the reason for this are either these three reasons. The expansion is not fully expressed clinically, and there's limited alveolar ridge or lack of buccal root bone. And reason number three is usually the most commonly seen reason in palatally hanging down cuff or overhanging palatal cuff on the upper arch. It's usually due to lack of buccal root bone when you are doing expansion, lateral expansion, or distalization. So we can increase the buccal root work so that we're able to keep the palatal cuff from hanging down and giving the buccal surface a more lingual root work. So this side can come more to the lingual side and allow a better interdigitation with the lower molars. And luckily, after AA, he is a very slow wearer, okay? We're able to adapt his midline and make it coincident with each other on the upper arch and lower arch. And that is Mother Nature. If the canine are on and the patient has no Moulton discrepancy, the midline will be on. If the canine are class 1, the midline is not coincident with each other, there is Moulton discrepancy. It's impossible to make the upper and lower midline on with each other if the canine are already on. Okay? So don't promise your patient that, oh, you're going to help him correct the midline. If you correct the midline, you're going to destroy the canine relationship. And I will always select the canine relationship more than the midline. I don't have midline on with each other. Okay? In order to get the midline on with each other, it has to be very very particular, everything has to be right. The size, the morphology, the relationship, okay? But sometimes it's good, and sometimes it's okay or all right if the midline are not coincident with each other. Because now with the marketing, with a lot of information on the website, patients think it is wrong, or it is not correct, or it's something, there's something wrong, with your treatment because your midline is not on. And I have patients that come in asking for a 0.05 millimeter change of midline. Okay, he will tell me that he still needs 0.05 millimeter of midline. He measured with a very small ruler and tells me that he wants it on, with the upper midline, and that's crazy, because us as dentists, we are not computers. So it's hard for them, hard for us to do all those adaptations. Now, with the feature of differential and asymmetrical advancement of the lower arch with the precision wing, it's very promising for midline issues, okay? Especially in kids in the mixed dentition, in which they are not very compliant in using the elastics. You can use the MA as a source of transverse correction to correct the midline and adapt the midline. So this is one of my younger patients, as you can see here. Okay, he still has his baby teeth, residual teeth. Okay, and then as we are, decalling on the upper arch and correcting his leveling and alignment, we try to adapt his midline without him using any elastics. We put on the MA for a short time, and we utilize the asymmetrical advancement, okay, to help with the midline adaptation on the upper and lower arch. So can you see that mandible advancement comes in after some aligners. So the first few aligners are the pre-MA phase. And with the pre-MA phase, it takes 4 aligners, at least 4 aligners. So if you're going into the pre-MA phase, you cannot just have 1. You will have at least 4 aligners, just like MA phase. You will have at least 26 aligners. You cannot have anything less than that. If you're using MA, you cannot use anything less than 26 aligners. If I'm not wrong, I assume it's 26. So let's take a look here. So you can see that MA does not come in after stage 7. Okay? So we do the expansion of the upper 6, lower 5, and lower 6, and after it's more aligned in the art form, the system gives the mandible advancement. Now with the clean check, I think it's very safe in doing treatment because they have a lot of warnings and a lot of calculations and algorithms to help us foresee whether we are in a good position or we are in a good treatment with the patient. If you have heart collision, the software will detect and they will let you know. They will ask you, do you want to free the occlusal interferences or the red occlusion at the end of the treatment? And if you have teeth are still crowding and you want to put MA, the system will not allow that. They will reject, okay? And they will tell you, oh no, not MA now. You need to level and align the posterior before we can trigger the MA to the patient. So expansion and decrowding simultaneously with MA treatment. So there's no time wasted. Everything is efficient, everything is planned, everything is precise, everything is according to the plan. Now, doing orthodontic is not when the patient comes back, you look at the patient and then you do what you see. Now is you foresee the future at the beginning. So you begin with an end in mind at the beginning. So you know, and you get to learn more about how teeth movements move in any patient. And you are more able to understand the biomechanics of different types of tooth movements. Intrusion, extrusion, distalization, expansion, flattening of first B, derotation, okay, marginal ridge adaptation, and all those types of different tooth movements. Because you can see visually, clearly, with the 3D model, with the CleanCheck modification, locally and lingually. I am trying to change my habit nowadays for the past 2 months. We tend to look at the mouth clinically with our patient, even if we scan. So we scan, we look at the mouth, and then we look at the scan. Now, I scan, I look at the scan first before I look at the mouth. Because usually we will tend to see less with our eyes intraorally. But with the scan, we're able to flip. And usually when I check the scan first, I will see the caries on the distal of 7, in which I don't usually see in the mouth. And I can tell the patient, oh, you have those cavities and you need it fixed. So, you know, scanning, trust your scanning because it's very precise and it's there. And images are good and sharp and very clear. And now with the Align Oral Health Suite, I also use it. I use it a lot for the occlusion, for the bite, the heat map. Okay? In patients that are deep bite, anything red, I will tell them. And there's the evidence that they need to be careful that after treatment, maybe they need on-leg or mon-leg. As you know, mon-leg plus in-leg, okay? It's very popular in our market because more protection. And usually, patient would be after treatment because you you elevate or you correct the vertical dimension, there's a clearance, there is a space, and you need to fill the gap. And with the gap, you're restoring the missing occlusal surface in deep bite patients. And usually they will need an onlay or a monglay. So this is the patient on the upper arch and lower arch and changes. And his changes in the smile. Look at him, totally different in muscle balance. Not only the smile, but the muscle balance is totally different. His change in his chin button, because he has a less overjet discrepancy to start with. His facial profile is better at the end of the treatment. You can see that the chin button is better than the last patient. And his growth is much better. The lower lip is more, it's advanced more anteriorly. He's a good patient. Even though he doesn't wear his aligners as compliant as the last patient, but he listened to me. He has his wisdom teeth all extracted before putting on his Viveras. And this is his changes in the centrometric, okay? The upper and lower incisal inclination. And look at his airway. Okay, the hyoid bone, and that, and there's more clarity in the airway. Now go back, always check the airway in your patient. Okay? Even if you don't do myofunctional treatment, after the advancement of the mandible, you are able to expand the airway. And together with myofunctional exercises, it will add to the effect. However, if you only do muscle exercise, it's not going to help. If the mandible does not advance, the airway is still collapsed. So myofunctional exercises has to go hand in hand together with dental treatment, with orthodontic treatment, and it will, win-win together. But together with only muscle function, you are only able to correct the mouth breathing to no breathing. But with this type of airway, it's hard to correct with only muscle exercises. So we're able to correct the overjet from 6 millimeter to 2 millimeter. And they are all very stable because most of my patients, they come back every 6 months for a dental, for routine retainer checkup. So usually they come and pick up their Viveras at the front desk or reception, and they come back. The first follow-up visit is at 6 months after the Vivera wear. And they all understand because our staff will instruct the patient, will train the patient to put on and take off and give them the instructions on how to use the Viveras. And if they have any problems, they're all able to communicate and contact us, not through the phone, through line. Okay? And even if they send us a message at night, the next morning when our staff comes into the clinic, they are able to process the messages and the issues that the patients are facing. So it becomes very convenient. The patient does not have to come in for just a little ouchie and a little crush there on the aligner. Our team is there to support the patient. So for him, there is an increase in the lower facial height, okay, and intrusion of the lower incisors. The blue is pre-treatment, yellow is post-treatment. You can see here, so that intrusion in deep bites is evident for flattening of the speed. Because a lot of doctors, when they use aligners, they see that intrusion in aligner is not evident. After you incorporate or you design intrusion on the lower incisor, it will become tipping. Okay? The thing here is you need to use you need to use power reach on the upper arch, or on the lower arch, you need to have strong attachment to hold the incisors in position. And utilize the G5 deep bite technology behind. So that is the second case of MA. Are we going to take a rest? Okay, let's take a rest. Okay, move around and then get some coffee, and then we'll come back for